Kelvin Ung is a stroke physician that trained in general internal medicine, clinical pharmacology, and stroke medicine in London and Nottingham in the United Kingdom. He completed his stroke fellowship at McMaster University before joining the faculty. He was a National Institute of Health and Clinical Excellence Scholar in the United Kingdom and was involved in technology appraisals for dabigatran prior to its introduction for England and Wales. His academic interest in therapeutics is focused on the use of novel drugs and treatments for and other chronic disease states. Apart from being a stroke and general internal medicine specialist at the Hamilton General Hospital, he's a keen driver for integrating and aligning clinical research with best clinical practice and is a current recipient of a Castor grant for disseminating clinical research into our district stroke centers. So I'll hand it over to you now, Dr. Ung.
Thank you very much, Tina. And again, thank you very much for the opportunity to give us a talk on intracerebral hemorrhage. Just some housekeeping. I have no conflicts of interest to declare. I strongly encourage the audience here to contribute questions. Chat probably is the best option, but please feel free to ask questions if you like as well. I always get a lot more out of this when I'm in touch with the audience. The objectives are fairly short. I thought I'd focus on principles of acute ICH management, but also taking it a step further where I think the audience may find it more interesting, taking secondary prevention beyond blood pressure targets. It is the pillar of blood pressure control, is the pillar of intracerebral hemorrhage risk reduction. But I wanted us to look at a more holistic view on how we can prevent hemorrhagic strokes from occurring. So without further ado, let's just start our discussion with a quick introduction that you may have already heard from some of your speakers on intracerebral hemorrhage. But for those of us who take care of stroke patients, we deal with a population that is only getting larger and larger. Canada is a population that's getting older, and strokes remain predominantly a disease of the elderly. It is #1 cause of disability in Canada. It is #2 cause of death. It is not a niche condition, unlike some other neurological conditions. So it is incredibly common. Even if we don't work specifically in a stroke program, nearly every clinician or provider of healthcare will end up taking care of a patient with a stroke. Now, for the purposes of this talk, I'm talking about hemorrhagic strokes, and they amount to about 1 in 6 of the strokes we encounter here in Canada. To put this in perspective, this 1 in 6 contrasts with about 50% rate in other countries, especially countries that do not have effective primary care. So countries like China, India, Africa, hemorrhagic strokes account for about half of all their strokes. The discrepancy is predominantly due to the fact that we have good blood pressure control here in Canada. You can't get a haircut or see a dentist without your blood pressure being checked, or walk into a pharmacy without your blood pressure being checked and hypertension being diagnosed and treated. Whereas in those countries, people generally tend to be reactive to conditions. So hypertension, the silent killer, tends not to be diagnosed until they've had an endpoint like a heart attack or stroke. So about 1 in 6 of strokes here in Canada. It carries a disproportionate amount of morbidity and mortality. So intracerebral hemorrhages account for 50% of all 50% of patients with ICH will unfortunately die. And about only a quarter of patients will return to functional independence. This again contrasts significantly with our ischemic stroke populations. So it's a much meaner, nasty beast compared to ischemic strokes. And very similar to strokes, however, it is part of a continuum of care, and sometimes we do focus a lot on the acute stroke management. But I want us to think of the bigger picture. Intracerebral hemorrhage fits in a wider continuum of stroke care, including secondary prevention outside of our stroke units, and also recovery and rehabilitation, which I'll touch on. But fundamental principles of hemorrhagic strokes remains the same as strokes as a whole. Time is brain, time is of the essence. It is an emergency, often managed by dedicated acute stroke teams. Here in our region, we have coordination of the EMS. We get pre-alerted when cases come in. We deal with them very quickly. Our regional stroke centers are organized in the hub and spokes model. There are multiple specialized teams, and your regional neurosurgical and neurointerventional teams are based here in Hamilton General. A regular audit cycle And through small improvements, the Japanese lean management ethos, it has been responsible for a lot of the successes and how we've managed to make ourselves more efficient and effective. So how do we manage acute hemorrhagic strokes? It is a medical emergency. The sooner you come in, just like ischemic strokes, the more the better the outcome. When patients come in with a hemorrhagic strokes and a stroke is suspected, we often have the first thing you do as soon as you can, and it's safe to do so, is to take the patient for a CT scan of the head. We, in our center, almost always do a CT angiogram as well. We do this even when we've identified a hemorrhagic stroke on the non-contrast CT, so that it's done just to find a leaking artery or a defect in the vascular system, an aneurysm, an AVM, and sometimes a CVST. The way I explain this to patients is that ischemic strokes are due to blocked pipes, blocked plumbing, whereas hemorrhagic strokes are due to leaking plumbing. So we still need to look at the plumbing, and that's angiogram is the best way to do that. Clinically at the bedside, you want to know how bad the stroke is. Two ways: assess their neurological impairments with the NIH, but also a GCS, particularly a Glasgow Coma Scale, to assess how alert, how high risk these patients are. These patients can get sick very quickly and get worse. Just a quick revision of strokes. Because it's a plumbing problem, what's unique is that for the average person, our cerebral blood flow is maintained as a constant across all ranges of blood pressure. That's what the mean arterial pressure below is. It's generally a straight line that you see. So no matter what my systemic blood pressure, when you measure it, is cerebral blood flow is normally preserved not within a tight range. When we have a stroke, ischemic or hemorrhage, the brain is unable to regulate itself. So cerebral autoregulation is lost. And what you end up finding is cerebral blood flow is very dependent on systemic blood pressure. Now, in the case of ischemic strokes, you want to let blood pressure run high. But in hemorrhagic strokes, when there is blood, there's a potential for an expanding hematoma, for the blood to continue to leak out of the artery. We want to lower the blood pressure to reduce the risk of the hemorrhagic stroke getting worse. By reducing blood pressure, you hope that you reduce the risk of more leakage of blood into the wrong place. Just like this diagram here shows. So if we identify a hemorrhagic stroke on our CAT scans, we find that there's nothing major leaking from the arteries. So it might be maybe a smaller blood vessel or is not leaking currently. How do you manage blood pressure? Canadian Stroke Best Practice recommendations talk about aiming for 160, ideally in the first 24 to 48 hours acutely. That's remains and has been the pillar of treatment. The sooner you lower the blood pressure, the better the outcomes. There have been numerous studies suggesting a lower target, less than 140, INTERACT-2, ATTACT, ATACH, and none of them have demonstrated a superiority of aiming for intensive control. There are flaws with these large internet randomized trials, but it is thought that maybe with hemorrhagic strokes, it's not so much a constant leak in the pipe, but more like a balloon that's popped. A hematoma expands and stops itself very quickly. Those that do not stop themselves, unfortunately, the patients deteriorate, and unfortunately, a lot of them die before they get into the hospital. Those that get into the hospital are alive because by and large, the majority of them, the hematoma has stopped. It's expanded and stopped expanding any further. So it may be the fact that a certain population of people where there is a risk that the blood will continue to leak will benefit for intensive control, and we'll talk about that. So typically we target about 160 milliliters of mercury systolic. And for some patients, we may target a lower target of less than 140. People you target, the lower target may be less than 6 hours onset, very high blood pressure, people on anticoagulation, so a predisposition to continue to leak blood. And then we have neuroimaging markers of expansion, which I'll touch on. And it's safe to aggressively lower the blood pressure when their renal function is good. So what is this hematoma expansion? Those people where the blood continues to leak. About a third of patients, when you see them early, will have this. And this is known as the spot sign. The big diagram you see there is when you inject dye, a contrast ink, into the CT angiogram, you see the hematoma, the big round splodge here. If you can't see my thing, you see contrast going into the hematoma. So we call that the spot sign, where it looks like the dye they injected is actually actively being pushed into the hematoma, which suggests that it's still leaking. And that's one of the markers of hematoma expansion. Larger bleeds are worse and they look more dramatic. Patients on anticoagulation or TNK. So how do we manage blood pressure control? Several thoughts have been brought up. Should we just continue on the blood pressure medicines if they're already on it, known to be antihypertensives? No, there was actually a stroke study called a STOP study, and they continued to give people their home blood pressure medicines after a stroke, and actually it didn't show any benefit. If anything, it was a negative study because there was a hazard of complications, including aspiration pneumonia, which makes sense. Our stroke patients may be able to swallow initially, but if you keep giving them pills, the first 24 hours is very dynamic, and some of them may choke on their pills and aspirin. People talked about intensive and guideline blood pressure control 160, and I mentioned there were two major studies, INTERACT-2 and ATTACK, that showed no benefit. So if you use 160 or 140 in a smaller population, what drugs do you use? We typically use intravenous drugs because we try to avoid oral agents and we want it to work very quickly and reliably. So labetalol is the most common used one. Labetalol is an alpha and beta blocker, unlike metoprolol. Metoprolol is just beta. So labetalol is good because when you use it, you don't affect cardiac output. It reduces the contraction of the heart, reduces the heart rate. So and lowers the blood pressure, but it also allows arteries in the peripheries to relax. And so by allowing them to relax and reducing resistance, you maintain cardiac output, which is not the case for the other beta blockers. Labetalol is the only one in this class that has an alpha effect that allows the arteries to relax, and so it doesn't affect cardiac output. And the thought is that by lowering blood pressure without affecting cardiac output, you don't increase the area of penumbra around the hemorrhagic stroke, the rim of tissue around the bleed that's squashed and prone to die. Just theoretical. It works quickly. Most people who are in acute strokes, they are a bit tachycardic because they are very stressed and in a fight-flight response. Labetalol works very well to lower their blood pressure acutely. It works very quickly. When you give it, you see the blood pressure coming down. Secondary agents, if we've given 5, 10, 15 and no effect, we usually give hydralazine, another IV drug, an arterial vasodilator. Another reason for using hydralazine is that in some of our patients, they can be very bradycardic. And if they're bradycardic, the nice foil to that is to use hydralazine, which can cause tachycardia. And it is, again, effective, works very quickly, lasts for a couple of hours after giving it. Just be careful, hydralazine inhibits breakdown of nitrates. Don't give a nitrate patch when you're giving hydralazine, or look at their patients' medications to make sure they're not on a nitrate donor, like a nitrate patch, because it can make hydralazine very unpredictable. Those drugs donate nitrates, and then you give them intravenously a drug that blocks the breakdown, so they can have an exaggerated drop in BP. Other drugs we use is the ACE inhibitors, enalaprilat, which is the IV version. It's not a prodrug, it's the active metabolite itself. It works very quickly. For those of you who are unaware, enalaprilat is essentially derived from the venom of the Brazilian green viper. So the green vipers in Brazil use it to eat their rodent, to paralyze their prey by making them faint and eat them. Enalapril is derived from snake venom, and the reason I tell you this story is that enalapril works very quickly. Enalapril has been modified so it works longer. So it's a medium-acting, medium-duration ACE inhibitor, but all ACE inhibitors work very quickly. Probably because in nature they were used as venom in its natural form. Other drugs that you can use to control blood pressure is nicardipine. We don't use it very much. Diuretics, again, we don't use it much because it's difficult to predict and quite slow acting. And sometimes if you have no vascular access, none whatsoever, you can try a nitrate patch as a last-ditch measure. So lowering blood pressure to reduce the leakage of the pipe, just as you saw in the graphics, is an obvious acute treatment. Other ways to manage a leaking pipe, a hemorrhagic stroke, is maybe to plug the hole. We've thought about this and tried multiple agents. We've tried factor 7, called Nova-7 in acute intracerebral hemorrhage studies. We've even tried, the most recently was the TICH2 study, TICH2 study, where we use tranexamic acid, a common medication that's used for menorrhagia, but effective in its use, cheap, widely available in trauma. We thought we'd use it in intracerebral hemorrhages, large study. Unfortunately, like all the hemostatic studies, when used for an unselected population of hemorrhages, the studies have generally come back neutral, no effect. I think coming back to my underlying principle of these hemorrhagic strokes, it may be because hemorrhagic strokes are like balloons that pop. They expand very quickly, and the ones that we see in hospital, the majority of them have already stopped expanding. So even if you plug the hole, the body's already plugged it themselves. We might use tranexamic acid, the most recent one that had the most promise. Not in guidelines, but some of us experts in the field will consider using it in people who present within 2 hours, because the sooner you give it, the better, the more likely that you're going to select a group that will expand. But we may use it for the high-risk population, the ones we talked about, those already on anticoagulants, those that have a spot sign where you can see blood actively leaking out, or people who have a very large bleed. You are excused if you don't give it, because the guidelines, while we think it's a good idea, a lot of the studies have been fairly dismal. It's not really been positive. So it's not really a standard of care. But out of desperation and maybe out of need to do something, in the worst of the cases, we sometimes give tranexamic acid IV. Now, the evidence for hemostatic treatment is, or the most consensus is actually used in people who are already taking anticoagulants. People who take anticoagulants have a 3 times increase of mortality. Remember, intracerebral hemorrhages already have a high mortality. People who are anticoagulants have even much more. And they have a 6 times increase that the hematoma will get bigger. So it very clearly identifies this to be a high risk population. The main anticoagulants that people take are drugs like warfarin. And in warfarin, we give them PCC. The Bigatron, another one that's widely used for stroke prevention and AFib. We actually have a monoclonal antibody reversal agent called idaruximab, right at the bottom down here. And that drug is so effective and so quick to work that as soon as you give the intravenous drug, all the effects of the Bigatron reverse reliably and irreversibly. So reliably that in ischemic strokes, in patients with the Bigatron, we sometimes will give them idaruximab to reverse their anticoagulants and then thrombolyze them if we are confident this is due to a thrombotic embolic stroke. Anyway, that's outside the topic of this talk. Factor Xa inhibitors, that's apixaban, edoxaban, rivaroxaban. We still give PCC, but if you have available in your center a new agent, Andaxnet alpha, is also available now. Now, this is not an irreversible antidote to the Xa inhibitors, but it is quite quick acting. It is less predictable, that in the sense that you have to recheck the coagulation factors to be sure you don't have to give any more. But it is different and less reliable than idaruximab, but there is an agent out there for those of you who have access to Andaxnet alpha. Otherwise, for most people, it is PCC will be the pillar of the treatment for the Xa inhibitors. So you lower the blood pressure, you try to block the hole. What else can you do? Neurosurgery. So all intracerebral hemorrhages ideally should be referred to neurosurgery. And the reason you refer to them is that some of these patients can get worse if they haven't already done so. Signs of getting worse is that their deficits are getting worse, they're getting more drowsy, especially when you have blood leaking into the ventricles. The ventricles have CSF, and the blood can actually block the drainage of the ventricles. They can get hydrocephalus. These people may need an external ventricular drain, what we call an EVD. And only neurosurgery will do this. So you call them, if there's signs of intraventricular hemorrhage, these people might be transferred under the care of the neurosurgeons for closer monitoring and EVDs. So other populations that you have to remember is if their bleed is in the posterior fossa, so the cerebellar hemorrhages, almost certainly have them transferred to a neurosurgical center, because the posterior fossa is a lot smaller. There's a risk they can cone and herniate, given the small space with a cerebellar hemorrhage. Other populations that may benefit from neurosurgery are those with a superficial location under 1 centimeter from the cortex. Young studies have shown that the younger benefit more than the old. At least the benefit has been in the young. Those where they have cancer and have high risk of bleeding, which may need decompressive surgery. Any questions from the panels about the acute management of intracerebral hemorrhage? Okay, this is all the acute stuff. Now I think this is the one that I thought might be more of interest. So secondary prevention beyond blood pressure targets. So typically long-term prevention of recurrent intracerebral hemorrhages is to target a low blood pressure. Canadian Stroke Best Practice recommendations do highlight that you should target a blood pressure of under 130/80. Other things that I want to highlight that people don't always focus on is the role of automated office blood pressure monitoring. Just checking a blood pressure is with a stethoscope no longer recommended. It is recommended ideally your patients have their blood pressure monitored outside in the waiting room, where it's quiet and you have an automated machine that will take several readings and which you discard at least the first reading. Now, even that is not thought to be the gold standard. The gold standard is actually out of office blood pressure monitoring. And the two most commonly used ones is home BP monitoring and ambulatory blood pressure monitoring. It really helps to identify people who have circadian rhythms to their blood pressure, but also for those who have white coat hypertension. Home blood pressure monitoring is easy enough. You buy a automated blood pressure cuff, and you give your patients a diary and you ask them to log time and blood pressure reading. And when they see you in clinic or when you're seeing them in rehab, you asked to look at the blood pressure book just to see how well controlled they are at home. And this is generally thought to be a much better gold standard assessment of home. Now, if you have access to ambulatory blood pressure monitoring, where they wear a machine that automatically checks the blood pressure every 15 minutes to half an hour over 24 hours, it's even better, though there is limited access to this resource, and it's usually preserved for those where you believe that the patient has white coat hypertension. But these out-of-office blood pressure monitors collectively is what I would normally strongly recommend when patients leave hospital with intracerebral hemorrhage, to know that the blood pressure is well controlled. You use the best agent to control the blood pressure. Started the first line agents that most of us are familiar with: ACE inhibitors, the thiazide type diuretics, the calcium channel blockers. The one thing that is highlighted in Hypertension Canada, but not in our stroke best practice recommendations, is a tilt towards single pill combinations where possible. There was a study that has suggested that it was more effective than drugs when they are separated in pills, and I suspect a part of it is not the magic of combining pills together like a salad, but more the fact that it helps with compliance. About half of our pills that you prescribe to patients, especially in younger patients, are not taken regularly as prescribed. They may take them every now and then, but half of the time they don't take it every day. And single pill combinations just helps our patients roll it into a routine in the day. And there are some logical combinations as well. ACE inhibitors and amlodipine, what we call a logical combination. Amlodipine, very effective, sustained blood pressure control, stroke risk reduction, but about maybe 5% of patients can get leg swelling, peripheral edema. Never that bad, but it's something that patients notice. When taken in combination with an ACE inhibitor, and you can put it in a single pill combination, they do exist, it seems to slash the risk of leg swelling by more than half. So not only do you get the benefit of better blood pressure control by using a combination and the synergy, you also have better tolerance because you have less side effects. So win-win. Now, outside of blood pressure control, just targeting this magic number of 130/80, which is the mean blood pressure, what else do you do? So this is one study back in 2019, just before COVID hit us, that I like referencing, and it talks about blood pressure variability. It's been known for a long time, and I used to follow the work of Peter Rothwell down in Oxford with his observational trials in the Oxfordshire database, where it demonstrated that people with blood pressures that jump all over the place seem to have greater risk of strokes and heart attacks. This Lancet paper used the PROFESS trial, 20,000, one of the largest stroke prevention studies, using 4 arms. One of them was the clopidogrel and dipyridamole arm, and then the other one was telmisartan. But the crux of this subgroup analysis that I show you here is people with the lowest blood pressure variability, the lowest standard deviation, have the lowest risk of stroke recurrence, and so the highest chance of stroke-free episodes. So you see where those people whose blood pressure are fairly stable have the best outcome. Those in the middle have slightly higher risk, and those with blood pressures that are jumping all over the place have the highest risk of stroke recurrence. Practically, what does this mean? So whenever you're using first-line agents, I personally like using amlodipine and indapamide as an outpatient. Amlodipine, because it is long-acting and is very gradual onset, it tends to take a long time to work. Amlodipine prescribed today doesn't kick in till 12 to 24 hours after. So it's very slow onset. And because it's long-acting, it doesn't contribute to blood pressure variability. Indapamide is the same. And these drugs, interestingly, in all primary prevention studies, have shown significant stroke risk reduction compared to their shorter acting or rapid acting agents. In some of the studies, when you look outside of mean blood pressure, the other potential blood pressure parameter that might be of interest is nocturnal dipping. When we are born and when we're young, we tend to dip our blood pressure at night. As we get older, we seem to lose this physiological dip in blood pressure. So again, thinking outside the box of average blood pressure, if your patients take their blood pressure at home and they measure, and it looks like their nighttime blood pressure readings are high, they don't have the nocturnal dip, I sometimes will consider using a long-acting agent, but a quick onset, something like perindopril at night. So I sometimes dose my patients the perindopril at night, in part because it maintains the physiological dipping. I put this in italics because while it makes sense and I can using ACE inhibitors induce physiological nocturnal dipping, in patients, there have been no randomized controlled trials to show that it is superior to taking these medicines in the daytime. But again, this is not something that replaces some other treatment. If I'm going to give them a perindopril anyway, I tend to use these long-acting ACE inhibitors at night, and I use these drugs even though they're long-acting at night because they are quick onset. Snake venom, if you remember, Brazilian green viper. So they work very quickly within an hour to two when a patient takes it, but then they persist the action for up to 24 hours. This is a diagram recently last year that kind of gives us this recent move towards blood pressure variability and moving away from just mean blood pressure readings. The thought is that with high blood pressure variability, there's a negative impact on arterial compliance, cardiac function, sympathetic tone, and it tries to explain why patients have a higher risk of strokes. When we talk about blood pressure variability, there are different ways to look at it, beat to beat, or the circadian rhythm of blood pressure. We talked about nocturnal dipping and a morning surge. Interestingly, when you look at variability in this interesting paper, it talked about how weather conditions can affect our blood pressure variability as well, day to day. And it's interesting, when I looked at data with regards to weather and how it affects strokes, we've noticed in our stroke unit that January we had a lot more hemorrhagic strokes. And I do wonder whether the cold weather had an effect. And actually, it's been observed. If there was a study recently that showed that if you use 20 degrees Celsius, British Columbia, Vancouver weather, you compare it to Ontario here, when it was -10, there is actually a 3 times increased risk of strokes, hemorrhagic strokes, when the weather is cold. Now, don't read too much into it because we don't know the duration of exposure and everything else, but it looks like weather does seem to impact the risk of strokes. And some of you in work in stroke centers may have noticed this, that we tend to get more hemorrhagic strokes in the winter, less in the summer. Other things that you might consider, if you look at a day-to-day variation, is we had a Super Bowl recently, and I looked to see whether or not a previous German study had shown this, but in Germany, they had looked at the Soccer World Cup, and every time Germany played on the World Cup, there was an increased risk of EMS call-outs for heart attacks and strokes. It looks like here in North America, when the Super Bowl is playing, and if people are very involved in American football, if during the Super Bowl there is a noticeable spike in heart attacks and strokes as well. So it looks like these are things that are difficult for us to change, but it's interesting observations that our blood pressure can be affected by these things, and there is a risk of hemorrhagic stroke. Other things to consider: housing condition, regionality, and seasonal variations that we talked about just now. How can you modulate these things? Well, drug therapy is only one part of it, but there are other things you can consider. Things like to help reduce or try to maintain a physiological nocturnal dipping, things of improving sleep patterns, treating sleep apnea, stress. If stress is an issue, driving blood pressure variability, you try to remove the stressor. Often difficult because things that stress us the most are things that we have little influence over, such as the health, family, and finances. But maybe sometimes counseling, cognitive behavioral therapy might help. But it is important that to acknowledge that there are other factors that drive blood pressure that you may modify outside of pills and potions. So what else can you do outside of pills? So I'm just preaching to the converted here in this audience, but essentially it's the basics. But it's good to go through them. Get moving. 10,000 steps. 10,000 steps have been shown to help improve cardiovascular outcomes. The more the better, but 10,000 seems to be that golden magic number that has you already see significant benefits. Eat better, fruits, vegetable, grains, less fatty meats, DASH diet and the Mediterranean diet, the two most common diets that we recommend. Both these diets recommend cutting down salt. Take your meds. Seems obvious, but for those of us who are providers, try educating your patients. Ignorance and is often the biggest barrier in your patients being compliant with medications. So educate them on the importance of the medicines. Tell them why they take these medications and why it's important in their disease process to help control the blood pressure. Checking blood pressure seems to help as well. So just the act of monitoring your blood pressure seems to help people become more engaged in the health state and to take measures to lose weight, to lower the blood pressure. Now, losing weight is obviously a big benefit. The SELECT trial with Ozempic with semaglutide recently showed that there was significant drops in blood pressure and improvements in cardiovascular outcome when people lost weight. LDL, lipids, everything improved. So without drugs, losing weight is also a major benefit. Easier said than done, but if possible, something to encourage. Reinforcing the need to essentially nowadays stop alcohol and smoking. Smoking because of the inflammatory driver that may cause and aggravate the risk of recurrent strokes. The last one I mentioned, de-stress and sleep well. Not always easy. Stress often comes from things we have little influence over. And it's that very reason why things stress us out. But maybe mindfulness helps. If nothing at all, even if you have a stressful situation in your life, trying to build in sleep and focusing on sleeping well is important. The world is always a better place when you sleep better, and sleep does help improve your blood pressure. Stay warm, only because of that little vignette I mentioned earlier on. It looks like the temperature, our environmental temperature does have a part to play in stroke risk. But I put that in italics because it's not that we can change the weather. Outside blood pressure control, what else can we do to reduce the risk of stroke recurrence? Well, systemic inflammation has been something that we've always been interested in heart attack and stroke risk and cardiovascular disease, but it's had a resurgence recently because of recent discoveries of a way to influence it. So systemic inflammation exists often because of a comorbid state, because of a diet, because of our exercise state. People who are obese have higher systemic inflammation. You can measure it with CRP, IL-6 levels. But recent interest has resurrected the interest in systemic inflammation because a study used several studies using colchicine in acute coronary syndrome and heart failure have shown significant benefits in cardiovascular outcome risk reduction. Colchicine is not a new medication. It's a very old medicine. In fact, it's an extract from a flower documented and known since Egyptian times 3,500 years ago. It was like aspirin. Aspirin and colchicine share similar histories. They were inscribed in a piece of papyrus discovered in Egypt called Ebers papyrus, and they were used for arthritis. Aspirin has become what we know today, but colchicine, not a blood thinning agent, back then was used for arthritis. It's increasingly now being used for heart attacks and heart failure, and there is a lot of interest in our community using it for ischemic and hemorrhagic strokes. The COVAS ICH study, you see the banner down there, is a study led by Aristides Katsanos, an incredibly respected colleague of mine who's trialing its use in intracerebral hemorrhages to reduce the risk of recurrent strokes and to improve cardiovascular outcomes without using an antithrombotic agent. But again, something to think about. So that's the bulk of my talk. Now, just to give context to what I was describing, I thought we'd probably use a case discussion. Please put your hands up if you have questions for me as we discuss this case. Just to frame our discussion. So 72-year-old man, pretty standard, rubbing his head because he has a headache, agitated, vomiting, left hemiplegia. Pupils are dilated bilaterally and is tachycardic. He takes the Vigatrin for stroke prevention in the context of atrial fibrillation. Blood pressure is very high. His heart rate is fast. We already know he's a stroke even before he comes in. Left hemiplegia is what we call a focal deficit, where half the body is weak. There aren't many things that cause hemiplegia. The only thing that can cause that is a central cause, and the most common central cause for deficits that are acute, sudden, is a stroke. Sudden is important, and the fact that half the body is affected is important. I have the banner for the fast signs up there, and you already know it's a stroke before the patient even arrives. Can you tell if it's a hemorrhagic stroke or ischemic stroke? In reality, you can't. There is a little bit of a thought that hemorrhagic strokes tend to be positive symptoms, so they are nauseous, they're vomiting, they have headaches, they tend to have high blood pressures. But in reality, it's actually quite difficult to differentiate. When they've surveyed doctors to try to tell whether they can tell whether it's ischemic or hemorrhagic stroke, just based on the story alone, they get it wrong half the time. Now, back in the days when we couldn't get CAT scans, I guess it mattered. But increasingly nowadays, as long as you think it's a stroke, and they come into the emergency department as a stroke, you're doing a CAT scan already. And I think that's probably the right thing to do rather than try to guess. Brain imaging is done for this 72-year-old patient, and you see this big white splodge over there. Fresh acute blood is always white, and it's very obvious to see. Ischemic strokes are not as obvious to see, but hemorrhagic strokes for sure more obvious to see. And you see this balloon that's popped and is expanded. He's made it in the hospital because it likely stopped expanding or slowed down expanding, so that's why he hasn't died. You see this dark rim around it, if you can see my cursor, and it's thought that the brain is pushed outwards by the blood, and then the area, there's a rim of tissue around that's been pushed out, that's squashed against the healthy tissue, and that area also dies, not just because the damage caused by the trauma of the blood expanding, but also being squished and pushed to the edge by the hematoma, the rim. What else do we do? Well, in our center, we do a CT angiogram. If it's a problem of plumbing, we want to see the plumbing. So the CTA is done to exclude vascular malformation aneurysms. And that marker of contrast extravasation, this little dot you see in the hematoma, that's actually what we call the spot sign. 30 to 40% of ICH present within 3 hours. And this spot sign is very useful for telling us whether patients are likely to expand and get worse. When patients come, high blood pressure, his blood pressure was elevated. No surprise, because 80% of them are elevated. His was over 200, which means that it was high mortality. So he was a high-risk patient. Hemorrhagic stroke, hyperacute care. What do you do with this 72-year-old gentleman with a high-risk stroke? So you aggressively control his blood pressure with the agents I talked about. First-line agent I would have used is Labetalol. I'll use 5 milligrams. I'll give another bolus in about 5-10 minutes to lower the blood pressure, watch the heart rate. If he becomes bradycardic, what I'll do is I'll mix it up and give him some hydralazine and try to bring him down to 160. Given that he has got quite a large hemorrhage and he might be quite at risk of expansion with the spot positive, I will aim for 140 and I'll keep giving him drugs in a step-down level 2 setting to control his blood pressure. Consider hemostatic reversal agents. He's on the dabigatran, so in this case, I would give him the antidote, which is idaruximab. It works immediately as soon as I give it to him. Doesn't negate the fact I need to lower blood pressure, but I'll continue doing that. Now, he doesn't have diabetes, but if his blood sugars were high, we know high blood sugars predict poor outcome. We will start an insulin sliding scale on him to try to control his blood sugar levels. We're not aggressive with glycemic control, but we aim to bring it close to about 11 as much as possible, millimoles per liter. We have done studies to see if there's any benefit of intensive control less than 7, and almost all the intensive glycemic control studies in heart attacks, in strokes, in critical care have all come back negative, implying that it actually causes harm. And in a stroke patient particularly, is the harm of hypoglycemia and the damaged brain. So by and large, we start the scale, but we don't obsess about it. We let it run close to 11. And obviously monitoring patients. In this 72-year-old person, we do 12-lead ECG, we do blood work, we check his platelets, we might give him tranexamic acid if we think it's high risk, and we do further imaging. And I'll let you think what else we would do. It's intuitive, but most of us would do a CAT scan in 24 hours because we want to make sure that he hasn't gotten bigger. We can examine them, but we want to see if it's not gotten bigger. And we also often do an MRI scan. So in this 72-year-old, you do the MRI mostly to assess how much white matter disease there is. And we're looking for something called cerebral amyloid angiopathy. What is cerebral amyloid angiopathy? It's something some of us may not have heard of it, but it's an increasingly commonly diagnosed condition, especially now with MRI scans. Some colleagues, Ashkan, a colleague of mine, did a lot of work on it. It's currently a condition we don't have treatments, though there is soon this year, there will be a clinical trial using a biologic agent to help patients with CAA. But up until recently, there's been no treatments for CAA. More common as we get older. We don't really know what the predictors of why people get it, but we just recognize it when we see it. And when we see it, it's not a good sign because these patients are at increased risk of recurrent hemorrhages. It's a disease due to abnormal proteins that build up like Alzheimer's within the lining of the small blood vessels of the brain. These blood vessels are prone to blocking off, but in our case, they're more prone to popping because they get fragile. So these blood vessels burst even at low blood pressures. They don't need to have very high blood pressures for them to burst and cause a hemorrhage. There is a diagnosis predominantly made by MRI, and you look for certain markers here. If it's a lobar ICH, if you see these dark areas of lines here where it looks like they're stained with previous bleeds that the patient then wasn't aware of, or you see these holes here, it looks like Swiss cheese. This is what we call microhemorrhages, and they're posterior predominant, meaning they're always at the back of the brain. And using this modified Boston criteria, these patients are recognized to have an increased risk of hemorrhage, and that might influence your choice of treatment later on, and it may in this case. Acutely, what do you do for these patients? First 24 hours, you monitor them closely. Now, the next 24 hours after the hyperacute care, like all stroke patients, you want to mobilize them early. Typically, in our center, we are okay with them being mobilized as long as the blood pressure doesn't go over 160. Unlike hemorrhagic strokes, we worry that the blood pressure might spike, but to do this, normally in most stroke centers, the blood pressures are checked when they're sitting up, they're checked when they stand up, and then they're walked around the ward to see how they do. Be aware of orthostatic change. All these patients are often given intermittent pneumatic stockings. You can't give them prophylactic fragment because they just had a bleed. But what may surprise you is we're actually okay to start a blood thinning agent within 48 hours, and we have good trials that show that it's safe to do this. So only those cumbersome ball and chain stockings are only worn for 48 hours, and then after that we swap them over to fragment injections, prophylaxis. Over the next couple of days, we start to be more aggressive with their blood pressure, and typically, actually in hemorrhagic strokes, within the first 24, 48 hours, we actually become more adventurous, and we will tend to start more oral medications on them to target blood pressure under 140/90. Most of the time in our center, we're happiest when they're under 130/80, and that's what the guidelines recommend. As I mentioned earlier on, I tend to focus on blood pressure variability, and I tend to use long-acting, slow onset drugs preferentially in my patients. That's amlodipine in the hospital. But when they can maintain good oral intake, I use long-acting diuretics like indapamide and clothalidone. If they don't have nocturnal dipping, I tend to like using ACE inhibitors. I use ACE inhibitors too as a first line, especially when patients have diabetes or coronary artery disease or heart failure. But if not, I tend to use amlodipine a lot early on. Now, timing for antithrombotics is a tough one. Most experts I often get called as a regional center for advice about this, but most of us, as long as their blood pressure is well controlled and you have a reason to take warfarin or anticoagulants like valves or AFib, as long as their blood pressure is well controlled, we usually repeat a brain scan in about 2 to 3 weeks, and most of us will then start their therapeutic anticoagulation. Now, there are some people you may not ever want to go back on anticoagulation again. And one of those populations is those with cerebral amyloid angiopathy or those who've had a second hemorrhage already. In the past, there weren't many alternatives, but in yellow I have here, there is now the potential where you can refer these patients to a cardiologist, and they can do a non-open heart surgery procedure where they put and deploy a left atrial appendage occlusion device to block off the source of most of the clots in AFib. It's not our first-line treatment, but in patients where you are worried that they'll bleed if you give them blood thinning agents, it is increasingly becoming an option. You have to send them to the regional cardiology center for this procedure to be done, but it is an option. In recovery, what are the other things that you need to be aware of? Try to prevent delirium. I use regular Tylenol a lot, like our geriatricians, to prevent delirium. I try to help them with sleep dysregulation. Accepting there's limited evidence for this. If they can't sleep well at night, I tend to use melatonin, and sometimes I use trazodone, sedating antidepressant that is non-addictive, just to help patients get back in the day-night cycle. People who sleep well are more likely to rehab better and recover better from their strokes. It might also help with reducing and facilitating the blood pressure nocturnal dipping, and reducing variability, as I talked about earlier on. Don't forget, in our stroke protocols, we have a bowel protocol, and this is also important in recovery because you don't want them to spike the blood pressure when they're straining on the bowel. When you discharge our patients, we always ask for close primary care. I do emphasize, at least personally, I always emphasize the need for out-of-office blood pressure monitoring. And usually for the majority of my patients is I give them a log for them to write their blood pressures at home. And I review that in my follow-up clinics. But I also recommend they review that with their family doctor when they see their family doctor. For some of these patients, if you have the ability to, do an ambulatory blood pressure monitor. Consider referral for sleep studies if the patients have sleep apnea. As I mentioned, while it's not in our stroke best practice recommendations, it is in Hypertension Canada, and it may contribute to the hypertension and loss of nocturnal dipping. So with about 15 minutes left, I hope I've succeeded in covering the objectives here, principles of acute ICH management, and then I've given you some options of not outside of just mean blood pressure targets, blood pressure variability, inflammation, and also non-pharmacological interventions for controlling blood pressure. Thank you very much for your kind attention. At this point, I'll go to my questions and answers, and I encourage all of you to do the same. It certainly makes this more lively. Otherwise, I will just throw my own questions into the pot. I think the first question here I have, Stefan, shall I go through them? I've got Alan McDonald asking, can you comment on the role of NVS in the context of sedation? Alan, could I ask you what you mean by NVS? Feel free to.
I'm going to go and I think I have to actually change the
Neurovitals.
to say. Give me 1 second.
So Alan, I've got neurovitals in the context of sedation. I'm not sure what you mean. I mean, neurovitals is, to some extent, there'll be limitations when people are drowsy, and the GCS is probably the most useful one for us when they're drowsy. But typically, you've already had the answer. If patients are very drowsy, you're already going to want to rescan them because you worry that they've expanded or they've had hydrocephalus. It's the change in their neurovitals that matters rather than the absolute number. So someone who had a high GCS or good neurovitals, and then they've suddenly changed, that's the trigger rather than the absolute numbers. I hope that answers your question. And we try not to give sedation to our patients when they've had a stroke.
If you'd like, just you're able to speak if you'd like to respond or follow up.
One of the questions that I do get asked, and I'm not sure if the audience shares, is about goals of care discussions with hemorrhagic stroke. So you see these patients with very significant disability. People have asked me, and I sometimes see this when I'm as a consultant, when I get called to comment on goals of care when patients had a bad hemorrhagic stroke. When I ask all of you to look at your practice, how often do you see goals of care being discussed in the first 24 hours? Common, not very common, rarely in a stroke. As a rule of thumb, I personally am hesitant to discuss goals of care in the first 24 hours of any stroke. Most of us will wait 24 to 48 hours, and I don't think I'm alone here. Most of my colleagues will wait 24 to 48 hours before we discuss goals of care, no matter how bad a hemorrhage is. The problem is, one of the unique features of ischemic strokes per se is that patients are often at their worst when they first come in, and almost all strokes will get better over time. Now, I'm not being overly optimistic here, but I accept that there will always be a gap. There will be deficits left behind, and some will have a big deficit, some will have a little. But I think time is a good predictor. Those who do well tend to do better over the next 24 to 48 hours. Those who don't get worse over the next 24 to 48 hours. And I think that additional information is useful before we decide goals of care for most of our patients. So I think in hemorrhagic strokes, I usually would encourage most of us to avoid making rash decisions in the first 24 to 48 hours and leave that for later on, unless patients have already declared or previously stated to loved ones what their wishes are, or they're able to tell you that they wouldn't want anything aggressive early on. But by and large, we typically will put a pin on goals of care discussion for 24 48 hours before we do it. Okay, and then is there a question here, something about common and not common? Oh, common, yeah.
I think it was a response to your question, Dr. Ong.
Yeah, no, Sita, I may be different centers, but I generally would recommend it being done 24 to 48 hours after, not too quickly. Because some of them will do. Now, other things that might help you is that ischemic strokes tend to get better very quickly in the first 3-4 days. You see people who are weak in the arm or no movement start to move them again within a day or two, which is quite common in strokes. Hemorrhages, the one thing to be aware of is the first 3 to 4 days, you might not see much improvement because of the perihematomal edema and swelling there. Until the hematoma starts to absorb and inflammation settle down, given that it's very tight with the hematoma taking up all that space, you don't see that quick bounce back in hemorrhages in the first 24 hours. So sometimes I might even wait a little bit longer, specifically in intracerebral hemorrhages, just because of the hematoma expansion that you sometimes see. Mind you, if it is catastrophic and the hematoma is getting bigger 24-48 hours and there's nothing we can do about it, that sometimes can be a trigger for goals of care discussion. But don't lose hope if you think your patients who are stable vitally, but haven't shown signs of neurological recovery in hemorrhagic strokes, not as quickly as ischemic strokes. And I think that's partly because the hematoma is there, you have the edema, the disease process is different. You almost need the hematoma to start to shrink and the edema settle down before you start seeing the improvement in the patient. So there's a little bit of a delay in the hemorrhage compared to ischemic strokes.
Dr. Ong, can I follow up on that with a quick question? So if there is typically that delay, is the rate of recovery after that delayed period, would you say it's quicker or is it similar to that of ischemic stroke?
We don't know. I think the damage is there and persistent. I don't know if it's quicker. Maybe it just seems quicker because relative to their delayed improvement in the first 2-3 days. Typically, stroke recovery as a principle is a bit, Steph and I were talking about children because we have children, young children. Stroke recovery is a bit like learning. So the typical stroke recovery curve is that they're worse when they come in, and for most strokes outside of hemorrhagic strokes, you see that rapid recovery. Just as our children learn, they learn very quickly in the first few years of their life, and then it starts to plateau out. Hemorrhagic strokes, my read of it is that it's flat, but then they seem to get that steep recovery. It's delayed, almost as if they're held back, and then you start seeing that recovery after that early on. They do tend to plateau off after a while. I don't know enough whether that plateau is shifted or whether it's just the shape of the curve rather than the potential for recovery.
Thank you for that. And sorry, I got one more follow-up question to that. Then, Dr. Ong, would you recommend, at times, continuing to reevaluate and what I mean specifically for that is using our standardized assessment tools, continuing to reutilize those standardized assessment tools to get a clearer and clearer picture as we're starting to see that recovery?
I agree, Steph. So this was something that we've discussed before. When you're taking care of a patient with a hemorrhagic stroke, a lot of our targets that we're told is we have to make a decision about rehab potential within the first 3 to 5 days, and the average length of stays that we have 5 days. A lot of it's built on the majority of strokes, which are by definition ischemic strokes. With hemorrhagic strokes, I do wonder sometimes whether we delay or sometimes we'll provide more flexibility by allowing more time before we make a decision, knowing that the pathophys is a little bit different. They have this blunted early recovery that maybe you just need to give them a wee bit more time before we make a judgment call whether they will get better. Because I think sometimes you will find that some of them will surprise you, and I think some of us will remember those ones that surprised us. They did terribly for a few days, and we thought we started to lose hope, and then were surprised when they started getting better. And I think it's in part because you have the hematoma started to absorb and the edema was settling down, and then you start to seeing that their brain relearning again once it was unshackled from the edema and the hematoma. Any other questions? The delirium approach is something I do strongly recommend to all of you. Just be aware that the mind is as important as the body. I am always very cautious managing intracerebral hemorrhages. There's always a little bit of a sense of nihilism in the acute stage of management, because unlike ischemic strokes where we have all these treatments to offer our patients, we don't have a lot of effective treatments for intracerebral hemorrhages. The mind is as important as the brain. I always will stress to my learners, sometimes it's not what we give our patients in terms of drugs, but what you say to them. To give them hope, I think is important. In the darkest hour, when they think they're hemiplegic and they're not showing improvements, sometimes just encouraging them to not give up, to try, and that we are continuing to watch, to see and to try to help them and facilitate their recovery is sometimes important. So do remember, depression is probably the most extreme form of it, but sometimes it's important to encourage our patients throughout this process of recovery.